Okay. Today we don't have the video camera working, so I'll go through only the web images. Musculoskeletal system.
I've got bones for you over there if you need them at all or not.
Oh, what bones you have?
Just those ones that we cut down the middle. Or I can even bring them over here. That one we cut down the middle over here. The others are just normal bones.
Okay. Is that a cut section or a?
No, this way. Yeah.
Oh,
down the middle. Down the middle. That one.
That will be good because that would be a good comparison for this.
Did you want me to bring it over here?
Yes. Is it good?
Yeah.
Is it okay?
Yeah, I think so.
Thank you. That would be good. Okay, we'll go through now HN01, a very nice specimen. You can see the epicondyle there, lower end of the femur. That's the cortex, normal. That's the marrow. Actually, it will be trabecular bone with marrow tissue in between. And observe the tumor here exactly at the end of the metaphysis, and see the intact epiphyseal cartilage. That is difference between epiphysis and the metaphysis. Okay, that differentiation is still maintained, and that's very characteristic of osteosarcoma. Usually it does not involve epiphysis. And see the tumor and raised periosteum. Okay, see that's the periosteum. The periosteum has been raised here and the tumor is here. So this angle here, the cortex is thickened. That is that Codman's triangle, usually you see it on the X-ray. A reactive bone formation at the elevated periosteal surface. Again, that's a feature of osteosarcoma. Thank you. That's the normal femur to compare with this. Good thing is to observe the thick cortex and the very thin cortex at the metaphysis and the epiphysis. And here you are seeing the tumor, and also notice that the tumor is infiltrating into, and this cortex is being infiltrated by the tumor and extending into the marrow. See that area? Extending into the marrow. So this tumor is infiltrative. Although it looks well demarcated, stopped there at before the epiphysis, but it is infiltrating into the bone. And the whole specimen, if you look at it, this is the specimen. It looks like that chicken leg appearance or the drumstick appearance. End of the bone, fleshy tumor involving through the bone. Osteosarcoma, the commonest bone tumor, malignant bone tumor, common in children. Okay, and it typically clinical presentation is fracture following a minor trauma or spontaneous. So it's a pathological fracture. Okay, so that's the epiphysis. Osteosarcoma of the femur. Now, one other common tumor, the three common malignant tumors, that is Ewing sarcoma, chondrosarcoma, and this giant cell tumor. Now, giant cell tumor is between benign and malignant. It is something like basal cell carcinoma in the skin we study. It is locally aggressive, it destroys the bone, but usually does not spread, no metastasis. Now, again it affects the ends of the long bone, a fleshy tumor with areas of hemorrhage and necrosis. And usually a thin portion of the bone remains outside, meaning it is not infiltrative. It goes on expanding the bone with a fleshy tumor. Giant cell tumor. Giant cell tumor is just by the name, plenty of giant cells, multinucleated giant cells, which are nothing but like osteoclasts. Okay, it's an osteoclastic tumor. So it will be plenty of giant cells in the microscopy. We will go through that later. So giant cell tumor, locally aggressive, very rare metastasis. It is in between benign and malignant, and again a common type of bone tumor. Now this is an example of osteosarcoma of the tibia. Now notice the epiphysis here, metaphysis, and the epiphysis has been removed there, and you are seeing the tumor almost extending from diaphysis to the metaphysis. That's the shaft of the bone, and see the tumor again same, lifting up the periosteum and causing that Codman's triangle. Here is the tumor is here, see the line there, that's the tumor, and this is the reactive bone. And the tumor, although it looks like well demarcated, isn't it? It looks like well demarcated, elevated skin, but not breaking through the skin. But see that it is infiltrating through and through the bone, as though bone is not stopping it at all. So it is very infiltrative tumor. It has infiltrated the whole of marrow and the muscle, and that whole whitish gray tissue is osteosarcoma. Okay, osteosarcoma is a highly malignant tumor. Yeah.
You mentioned a triangle.
Huh?
What
Codman, C-O-D-M-A-N. It was shown in the lecture yesterday, I think. Codman's triangle. It's usually a diagnostic feature on an X-ray image. Okay, and that is because of bone deposition below or above the tumor. Here the tumor is rounded, it's here, very difficult to differentiate, and below is the thickening of the cortex, and that's just a clinical clue that it could be osteosarcoma. Got the point? Any more? Huh? No, he's still like this. Anybody can help me? Now, when you see this bone on an X-ray, you would see this area as the tumor rounded, okay, and here is the cortex or the thick portion of the bone, and this bone would extend as though it is supporting the tumor, lifting up the weight like a triangle. This area. Best thing is Google. Okay, see here, this itself, in the first one itself we could see. Now see this, that's a tumor, okay, see that's a tumor. Here is a triangular area of bone which is seen on the X-ray, and here is this triangular area of the bone, and that's a tumor, and this is the Codman's triangle. This is the Codman's triangle. Still doubt? Good. Okay, Codman's triangle. On the X-ray, you will see, and this is simply because of elevation of the periosteum. Elevation of the periosteum stimulates the osteoblasts below in the periosteum, and they start secreting bone more. Elevation of periosteum. Periosteum is the lining layer covering the bones where there are osteoblasts. Here, one more. This area is a Codman's triangle. which is not really part of the tumor, but it is actually extension of the normal bone. Okay, see, that's the area of the Codman triangle. Now, what I am trying to show is on the tumor, okay, here, and that's the tumor, through and through infiltrating. Now is HN04, another example of osteosarcoma. Is a bit old specimen. It has bleached, but still you can see the features. See, that's the lower end of the femur, that's the knee, patella is not seen, that's the upper end of the tibia, that's the cartilage, epiphysis, metaphysis, and the tumor. And the Codman triangle would be here. That's the tumor line, and that's the elevation of the periosteum, and this bone, which is the wall of the diaphysis, is expanded there. And see the tumor, it's a grayish white expanding tumor, but it also infiltrates through the bone, literally destroying the bone, and that's the tumor there. That's the knee, lower end of femur, upper end of tibia, and osteosarcoma from the metaphysis of the tibia. Now, bone cysts are due to so many reasons: congenital cysts, acquired cysts, osteitis cystica fibrosa. If, for example, if we use this in the exam, identification would be this is a dry bone, tissue has been removed, so it could be any tumor which is expanding. Most commonly that would be a giant cell tumor, or it can be simple cysts. Cysts can occur in the bone, but clinically important cysts are due to hyperparathyroidism. Hyperparathyroidism, wherein there is excess parathormone, increased osteoclastic activity, and dissolution of bone everywhere in the body, and it causes bones to form small cysts, multiple. Osteitis cystica fibrosa is nothing but result of hyperparathyroidism. Okay, so I'm just saying this one is just labeled as bone cyst. So bone cyst can be congenital, can be acquired by tumors or by hyperparathyroidism. You cannot diagnose what type it is just by looking at this specimen. It's simple, just a bone cyst. Now, another example, HN06, lower end of femur. Now, see the epiphysis there, joint, that is the epiphysis, condyle of the femur, metaphysis epiphyseal plate, and the tumor. Now, if you see this area would be the Codman's triangle, and see the tumor. Most other specimens were showing no hemorrhage or necrosis, but here there is some hemorrhage and necrosis. Okay, so this was diagnosed as osteosarcoma, and osteosarcoma can show areas of hemorrhage, necrosis, especially when it is massive, big, okay, and usually in the center, compromising of blood vessels. That's again osteosarcoma. So osteosarcoma is the most common. Clinically, what is the importance? Young age. Can osteosarcoma occur in adults? Anybody? Very good. In adults is usually secondary. Radiation, primary bone disorders, Paget's disease. In secondary conditions, osteosarcoma can occur in adults, but that's not common. Commonest is usually before teenage, usually, but young age, any age. And then presentation, spontaneous or fracture following minor trauma. And typically previous history, before the trauma or fracture or presentation would be fever. Very interesting finding. This is one malignancy where there will be fever. Fever, weight loss and local pain, just like inflammation. Osteosarcoma, although it's not painful as in trauma or osteomyelitis, mild pain, inflammation, redness would be there. Okay. And typically patients present with non-healing fractures if it was not diagnosed early. Gross features, remember this: location, metaphysis, Codman's triangle, appearance, the drumstick appearance, grayish tumor, infiltrative, limited by epiphysis. It does not usually involve epiphysis. Okay, so they're all the gross features. Microscopy, only pleomorphic cells with lacy amyloid. Lacy means fine fiber-like amyloid. What is that? Not amyloid. What is that? Lacy, osteoid. Osteoid, the precursor of bone, the protein mold. Normally it is the structure of the normal bone, shape of the normal bone, but it is protein, osteoid. So it will be like a trabeculae thick, whereas in this tumor it will be like a fine lacy network of osteoid. In between, pleomorphic cells, malignant cells. That would be the microscopy. Okay, we will go to the microscopy now. Okay, so that's about the gross specimens. Microscopy. Now, normal developing bone, just quickly, how it develops. Now, that's an embryo. The bones, articular bones, that is long bones, are usually formed by cartilage. So that's the lower end of the femur, this is the upper end of tibia. It will be cartilage, and there will be growth plate, that's the growth plate, breakdown of cartilage replaced by osteoid. See the osteoid, irregular osteoid, lined by plenty of osteoblasts. See, these are all osteoblasts. There will be few osteoclasts, and they are remodeling the bone through osteoid tissue. That's the cartilage. So breakdown of cartilage and replacement by trabeculae, the bone, and that is the growth plate. See that? That's the muscle there. This is the tibia. That's the lower end of femur, and that's the growth plate. So growth plate is nothing but area where there is dissolution of cartilage replaced by osteoid tissue. Now this type of osteoid you will see in fractures. Irregular, no fine lines, lamellae are not formed, and marked prominent osteoblasts lining them. If you just look at that, it looks like a building constructors putting the bricks there, lines of people. Okay, probably not here, but in India. Here probably machines would do. Okay, these are all builders there, osteoblasts. Now normal bone, just a cut section of a small, probably a carpal bone, thick cortex, and the thick cortex has lamellae, fine lamellae deposited with calcium, and these are the Haversian canals, central canals. Okay, and these small spaces where this dark blue nuclei you can see, they are the osteocytes. And remember that the nutrition to those osteocytes which are alone in the small cave in a dense concrete block of this bone, the nutrition comes from the fine cellular processes connecting to the central canal. So although it looks like it's solid bone, there will be fine spaces where they put cellular processes, osteocytes. Okay. Now that is the periosteum. Periosteum is a line of osteoblasts. These are the osteoblasts and fibrous tissue. That's the periosteum lining the bone. Usually they are inactive, normal bone, but when there is a fracture or inflammation, they will be hyperactive. Okay, and this is the normal marrow. You can see the megakaryocyte, that is both RBC and WBC forming cells, that is blast cells, and the fat. This is the normal appearance of marrow. So I'm just showing normal bone. Now there is fracture callus.
Sashi, with that picture of the bone before, is there periosteum both on the inside and the outside?
Always there will be both inside and outside. There will be lining. Even along the trabeculae there will be periosteum. But it will be thin inside and thick outside. Okay. Now this is the show you the normal bone and the irregular bone. That's a new bone. It is end of a fracture. Now if you see this part, okay, you can see the fine lines, trabeculae and osteocytes. So this is a normal bone. Okay. Now as we move, this bone is growing newer bone which are slightly irregular. There are no fine lines here and they are still bluish. That means DNA, RNA still active there. And this area has prominent osteoblasts compared to resting osteoblasts here. See that they are very thin, pale, thin, non-active, but as we move towards this new bone, these are active osteoblasts. And this bone which is without these lines, irregular, no fine lines, and osteoblasts prominent, scattered here and there, not like here along the lines, Haversian systems. This is oven bone, new bone, oven bone. Okay. So this is some biopsy from edge of the fracture. You can see the new bone being formed over the mature bone, and the marrow tissue that is surrounding the fractured bone is all blood vessels and fibroblasts. Plenty of blood vessels and inflammatory cells, RBCs. This is the granulation tissue, the healing tissue. Okay. So granulation tissue, osteoblasts, oven bone, and here is the mature bone. Here. Okay. So fracture, you will see granulation tissue, hemorrhage, inflammatory cells, and oven bone. Yes? Spelling oven is like weaving, W-O-V-E-N, oven bone. That is, it is still stitching. It is still not mature. It is still stitching raw. Okay, it's not O-V-E-N. No. Now osteosarcoma. Now that's the tumor. It may come from a fracture site, remember. So clinically it presents like fracture. So it will be a pathological fracture. And if a fracture is not healing, a biopsy will be sent, whether it is infection, whether it is malignancy. So a microscopy you would expect, or as a pathologist we would expect, whether it is fracture or whether it is a tumor. Now, if it is a fracture, you would see those woven bone, inflammatory cells, granulation tissue, whereas in a tumor, you see this. All the cells look like inflammatory cells. They all look like inflammatory cells, but if we see high power, they all look alike. They are all similar type of cells. They are osteoblasts, malignant, and the fine lacy, okay, lace-like, fine osteoid. That's all is the feature, okay, only two. Lacy osteoid and these osteoblasts which are irregular. So, pleomorphic cells. And of course, the clinical history will help you. Microscopy of osteosarcoma. Now, if it is an infection, osteomyelitis, now here you would see dead bone. Dead bone is like mature bone, but the osteocytes missing in the canal. So, you will see dead spaces, means empty spaces, no nuclei. Okay, that's a dead piece of the bone surrounded by plenty of inflammatory cells, plenty. And this collection of inflammatory cells in focal areas are nothing but abscesses. Okay. So, you will see plenty of inflammatory cells forming abscess with dead bone. That would be osteomyelitis. Now, briefly about Paget's disease. Paget's disease, as we discussed yesterday, anybody remember what it is? Pathogenesis of Paget's disease. Excellent. Excessive remodeling, excessive appearance like multiple fractures with remodeling. Okay, so it is trying to repair more, although there is no real fracture. So, excess turnover, both deposition and dissolution. So, microscopy of a Paget's disease bone. The bone itself, okay, we will just go through the discussion, clinical features. What would be the clinical features in a Paget's disease? Marble bone disease, yes? Yes, and becomes thick. Bones become markedly thick. Okay. One point. Then age, usually young to middle age. It can affect focally or it can affect every bone in the body. Pathogenesis, it's a genetic disorder. Uncontrolled continuous turnover, both osteoclastic activity and osteoblastic activity increased. Microscopy, gross, it is thick bone known as mosaic appearance. Mosaic appearance. Microscopy actually proves that feature. Now, if I show this, this is the microscopy from a Paget's disease bone, the trabeculae. What you see is mosaic pattern, irregular geographic patterns of blue and pink lines. And you will see the osteoblasts, osteocytes irregularly placed, just like in a woven bone. So, it's all woven bone everywhere. And see the markedly increased osteoclast. See, that's an osteoclast, this is an osteoclast, this is an osteoclast, this is an osteoclast. Plenty of osteoclasts. See here osteoclast. And you can see that osteoclasts are eating away the bone. And also there is deposition because there is increased osteoblasts also. Plenty of osteoclasts, plenty of osteoblasts, and woven bone everywhere. So, it's just like a fracture occurring everywhere, but it's not really fracture. But these patients are prone for fractures. Although they have thick, heavy bones, it is not strong, it is fragile, it breaks. Okay, so they do present with fractures following minor trauma, Paget's disease. That's it. I finished all. This is just a normal bone. I'm just trying to see if I can show the canals, but I don't think so. A very faint line. See, that's a Haversian system, central canal. This is a decalcified, unstained bone, and you can see those fine processes, cellular processes, which extend from the central canal to the osteocytes. That's it. Any doubts? For this week, you must know pathology of osteosarcoma thoroughly well. And Ewing sarcoma, just blue cells, not even important microscopy, but clinical features. Present just like osteosarcoma, same young age. It's only the microscopy which differentiates. Otherwise, both are malignant tumors. Giant cell tumor, locally aggressive, within the ends of the bone, produces cystic expansion of the bone with the tumor. Giant cell tumor. And then chondrosarcoma, I have not shown the pictures of the tumor. It is a malignant tumor of a cartilage, but occurring in the bones, chondrosarcoma. That is another common tumor, but not as common as osteosarcoma. So just know the name, probably that's enough. What are the benign tumors of bone? We gave a list yesterday. Very good. Osteochondroma, the commonest. Okay, exostosis. Osteochondroma, osteoma, simple chondroma, enchondroma, osteoblastoma. There are so many names, but the commonest is osteochondroma and osteoma. Okay, benign tumors, just bone forming tumors. Now, just for completion's sake, because we are completing all the connective tissue pathology, the tumors of fibrous tissue, fibroma, fibrosarcoma. Tumors of fat tissue, lipoma, liposarcoma. Histiocytoma, malignant fibrous histiocytoma. That's one more common name of connective tissue tumors. All these are benign or well demarcated, capsulated, malignant or irregular, infiltrative, pleomorphic. So all the general features apply. So just remember the names, because when you go into clinicals, these names should not surprise you. Okay? Osteoma, lipoma, fibroma, osteochondroma, tumors. Any questions? Have we missed any part? Now, in CPC 7, I have put more slides, but I wouldn't expect you to remember any of them, but I just kept it because you can have a look at it if you see a case in the clinicals you want to see. Now, the giant cell tumor, only one I'll show you just because we described that, and this is quite common also, giant cell tumor. So that's the giant cell tumor with plenty of osteoclasts. Okay, these are the giant cells, and that's all. And notice that even this tumor also produces osteoid, and plenty of these big multinucleated giant cells, multiple nuclei. Okay, that's all. Giant cell tumor. That is an osteoid osteoma, osteosarcoma, lipoma. Lipoma, fat tissue, congenital disorders, multiple endocrine neoplasia associated with. It can present as painful or non-tender masses under the skin, multiple lipomas. very common clinically, usually benign, does not produce much symptoms except for the pain, and treatment is usually just a simple excision. Now that's a lipoma, well demarcated, and high power view it will just show fat cells and no anything abnormal. It looks like just normal fat tissue, except that grossly it will be a well demarcated rounded tumor. It's very common clinically. Now this is osteoid osteoma, usually has a central cavity and a reactive small trabecular bone. This is whole thing is a tumor expanding within the marrow of a larger bone, and these are supposed to be very painful clinically and very common in the skull bones, osteoid osteoma. Okay. Ganglion, chondroma. That's enough.